Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Reema, and today we're tackling one of the most foundational themes in neuromuscular medicine muscular disorders. From floppy infants to fatigable weakness, from inflammatory myopathies to muscular dystrophies, this episode is packed with the patterns you'll see over and over again in clinical practice. And of course, I'm joined by the amazing Mace.
Hi, Reema, and hi, everyone. You know what I love about muscular disorders is that once you understand the core patterns, everything becomes much easier to recognize. You start to see how weakness can be proximal or distal, how tone can be too low or too high, and how classic clues like Gower's sign, calf pseudohypertrophy, or certain skin rashes point you in the right direction.
Classic signs leading you to a diagnosis.
Yeah, and the big picture really comes together. You learn how genetic defects cause congenital myopathies and dystrophinopathies, how metabolic issues lead to disorders like Pompe, how immune mediated damage produces conditions such as polymyositis and dermatomyositis, and how neuromuscular junction problems like Myasthenia gravis create fatigable weakness. Once these themes click, muscular disorders stop feeling random. They become a very organized logical system.
Before we jump in, can you give everyone a quick roadmap of where we're headed?
Absolutely. We'll start broad with what muscular dysfunction looks like, how tone changes, how to examine hypotonia, and how to recognize clinical clues. Then we zoom into congenital and genetic muscle diseases, things like spinal muscular atrophy, congenital myopathies, and Pompe disease, and congenital myotonic dystrophy. From there, we dive into the major muscular dystrophies Duchenne, Becker, limb-girdle, congenital dystrophies, and facioscapulohumeral disease. And we close with the inflammatory myopathies and myasthenia gravis, where the immune system and neuromuscular junction take center stage.
Perfect. Let's begin. All right, Mace, before we get into all the specific diseases, let's set the stage. What are the general ways that muscle disorders may present?
There can be a problem with tone. Muscles can become too floppy, too stiff, or stiffen the wrong way. Hypotonia is that classic floppy presentation. Spasticity is an increased tone that gets worse the faster you move the limb, and rigidity is increased tone no matter what speed you move it. Weakness is another big symptom, which may cause trouble keeping posture, clonus, myoclonus, you know those quick jerks, and dystonia, where the muscles sort of lock into the abnormal positions. Other than tone and weakness, some patients complain of direct muscle pain.
And the pattern of weakness really matters. For example, proximal weakness makes us think of dystrophies or inflammatory myopathies. There is another thing that gets confusing sometimes, which is the difference between central and peripheral hypotonia. Can you break that down?
Sure, when hypotonia is central, the issue is coming from the brain or spinal cord. Those patients usually have developmental delay, maybe some dysmorphic features, and the reflexes are normal or even brisk. Strength may be mildly reduced, but it's not dramatic. The muscles are small, reflexes are low, but cognition is normal and there is no dysmorphism. The problem is in the lower motor neuron, the nerve, the neuromuscular junction, or the muscle itself.
And you can actually see that difference on examination, right? Like when you're examining a baby.
Exactly. A floppy infant gives themselves away pretty quickly. If they have no head control when you pull them to sit, or if the whole body droops into the inverted U shape when you hold them horizontally, those are strong signs of hypotonia.
All right, Mace, now that we've built the groundwork, let's talk about some general principles in diagnosis.
We always start with clinical observation, which guides us on how to proceed. For labs, creatine kinase or CK is the main parameter. When muscle fibers break down, CK leaks into the bloodstream, and in many muscle disorders, especially dystrophies, it can shoot up.
Some muscle disorders are autoimmune, so checking for autoimmune markers or antibodies can be helpful in those cases.
Right. If you're worried about inflammatory myopathies, autoantibodies can support your diagnosis.
We can also use electromyography or EMG in some cases.
Yeah, it can be helpful sometimes. EMG basically shows how the muscle behaves electrically. In muscle disorders, the myopathic ones, the muscle fibers fire with low amplitude and short duration, and they often look patchy or polyphasic. It's like the muscle's trying to respond, but it just isn't generating the strong, coordinated electrical activity you'd expect.
And probably the most definitive diagnostic tool in many cases is the muscle biopsy.
Yep, a biopsy let us actually see what's happening. Under the microscope, we can tell whether muscle fibers are being destroyed, replaced by fat, infiltrated by immune cells, filled with glycogen, or forming structural abnormalities like rods or cores.
And finally, there's one test that has completely changed the game for muscle disorders, and that is genetic testing.
Yes, absolutely. For hereditary muscle diseases, whether it's DMD, SMA, congenital myopathies, or congenital myotonic dystrophy, genetic testing isn't just helpful, it's essential. It confirms the diagnosis, guides management, and helps us counsel families accurately.
So, putting it all together, diagnosis starts with a clinical picture, supported by CK levels, antibodies when needed, EMG patterns, biopsy findings, and when we suspect something inherited, solid genetic testing. Now that we understand how to diagnose muscle disorders, let's move to the congenital and genetic muscle diseases, the conditions that show up early after birth. When you see a floppy baby, what are the big categories you start thinking about?
A floppy infant could have a congenital myopathy, a congenital muscular dystrophy, a neuromuscular junctional problem, a metabolic disorder, or even a genetic syndrome affecting multiple organ systems. And as you said, what makes the congenital group unique is that the weakness is usually present at birth or during early infancy, not something that develops later on.
Right, and clinically, they often fit into certain patterns. Let's start with the congenital myopathies.
Congenital myopathies are problems inside the fiber. They don't usually cause massive CK elevations or rapid degeneration like dystrophies. Instead, the issue is in the architecture of the muscle. Three of the classic ones are nemaline myopathy, where you see these rod-like inclusions, core myopathy, where the fibers have areas lacking enzymes, aka cores without enzymes, and central nuclear myopathy, where too many nuclei cluster in the center of the fiber instead of the periphery. They often present with hypotonia, difficulty feeding, weak facial or respiratory muscles, and sometimes the need for early ventilatory support.
Okay, so nemaline myopathy has rod-like inclusions, core myopathy has areas without enzymes, and central nuclear myopathy has nuclei clusters in the center. These are the congenital myopathies. What about congenital muscular dystrophies? What's the difference between myopathies and dystrophies?
While myopathies are a defect in the architecture of the muscle, muscular dystrophies are degenerative destruction of muscles. Muscular dystrophies is a general group of disorders with muscle degeneration. But when we see congenital muscular dystrophies, we refer to a specific set of such disorders. These congenital muscular dystrophies are usually autosomal recessive and show up with diffuse weakness, poor feeding, respiratory problems, and sometimes fixed joint issues, called arthrogryposis, because the baby didn't move enough in utero and its fingers got squished. These kids may also have cardiac or even CNS involvement. CK tends to be higher compared to congenital myopathies, because CK leaks in dystrophy and degeneration of the muscles. And biopsy shows muscle destruction and fibrosis, a key feature in muscle dystrophies.
There are several types of congenital muscular dystrophies. Let's start with spinal muscular atrophy, or SMA. What features make SMA unique?
SMA is all about the lower motor neuron. The main problem is a mutation or deletion in the SMN1 gene. But the severity of disease is determined by the number of copies of SMN2. Babies with very few SMN2 copies can present with profound hypotonia and respiratory failure early on. It's one of the most severe cases of infantile weakness, but also one of the most hopeful recently, because of gene therapy like Zolgensma, which is a one-time infusion aiming to replace the missing gene.
It really shows how genetics is transforming neuromuscular medicine. And now that we established that SMA is a mutation of the SM1 gene, let's talk about Pompe disease, because they really love to ask about this one during exams.
Pompe disease is a lysosomal storage disorder caused by deficiency of the enzyme acid alpha glucosidase, or GAA. Without the enzyme, glycogen accumulates inside lysosomes and essentially chokes the muscles from the inside. Clinically, these infants are profoundly hypotonic, with massive cardiomegaly, respiratory failure, and often hepatomegaly. Without treatment, mortality is high in infancy. Luckily, enzyme replacement therapy exists, and early initiation can dramatically improve outcomes.
And of course, we can't talk about congenital disorders without mentioning congenital myotonic dystrophy. This is the one where examining the mother is just as important as examining the baby.
Exactly. Congenital myotonic dystrophy happens because of a CTG repeat expansion, and it shows anticipation. Anticipation is this thing in genetics where the condition gets worse with each generation because the gene segment that is repeated keeps getting longer. Mothers often have a classic delayed hand relaxation, but their babies have a more severe disease. The babies are born with severe hypotonia, poor respiratory effort, and sometimes facial weakness. They may need respiratory support right at birth. It's a dominant condition, but it hits the infants much harder than their parents.
So, to summarize, in congenital and genetic muscle disorders, we're looking at hypotonia from day one, patterns of weakness, systemic involvement, and very characteristic genetic mutations. Perfect, but we're still missing some muscular dystrophies, very major ones, in fact. So, I think we're ready to dig into the other muscular dystrophies that are not congenital. Now, we will discuss the rest of the muscular dystrophies that present in children and young adults, not in infants. These are the names everyone hears in medical school: Duchenne, Becker, limb-girdle, the whole family. And I think this is where patterns really shine. We already said that muscular dystrophies are genetic conditions where muscle fibers slowly break down over time and are replaced by fat and fibrous tissue.
Yup, and the key word in the disorders we're about to discuss here is progressive. These aren't sudden and they're not static. The muscle keeps weakening as the disease advances.
Right, and that's why families often notice things gradually. The child gets tired easily, falls a bit more, struggles with stairs, but at their core, all muscular dystrophies share that theme of ongoing muscle degeneration. One thing that can get confusing is, how do you tell these dystrophies apart? And honestly, the patterns are super helpful. So let's start with the king of all muscular dystrophies, Duchenne. How about a case scenario? Imagine a 5-year-old boy brought in because he just can't keep up with other kids. He started walking late, gets tired easily, has trouble climbing stairs, and when he tries to stand up, he pushes on his thighs to lift himself. His calves look big, almost muscular.
This is a classic presentation for Duchenne muscular dystrophy, or DMD. It's X-linked recessive, caused by a mutation in the dystrophin gene. Dystrophin is a structural stabilizer protein that anchors the muscle cell membrane so it doesn't tear every time the muscle contracts. So when you have a problem with dystrophin, the muscle fibers break down over time. Eventually, they get replaced by fat and fibrous tissue. In Duchenne, specifically, dystrophin is either completely absent or severely non-functional, so the muscle membrane is very fragile.
Before we go deeper into DMD, I want to point out an important distinction for our listeners. Dystrophinopathies come in two main versions, Duchenne and Becker. Both of them are a problem in the dystrophin gene. But the big difference is simply whether dystrophin is completely absent or partially functional.
Right. In Becker muscular dystrophy, dystrophin isn't absent, it's just reduced or abnormal. So the disease progresses slower, symptoms start later, and it's not as dramatic as Duchenne, where you don't have any dystrophin left.
Perfect. Now let's explore Duchenne in full detail. Because it's X-linked, it's more common in boys, and clinically these boys stand out early, right?
They do. The disease starts in proximal muscles, especially in the hips and thighs. They might walk later than expected, have trouble running or jumping, or struggle to get up from the floor. And that's where we see that hallmark maneuver, Gower's sign, where they push off their thighs to stand because their hip and thigh muscles are weak.
And then, of course, the famous calf pseudohypertrophy, the big calves that aren't actually muscle.
Exactly. It's full of fat and fibrous tissue instead of the muscle that's been lost, which explains those big, firm calves that look strong but actually don't function well.
Since it's a type of muscular dystrophy, CK levels would be elevated.
Yes, CK levels are usually extremely high, like 10 times the normal range. because the muscle fibers are constantly breaking down.
So early on, families might notice clumsiness or slow walking, but over time it becomes much more significant.
Right. Most boys with Duchenne lose the ability to walk by around 12 years old, and the disease continues to progress toward respiratory decline due to weak respiratory muscles. It may even lead to dilated cardiomyopathy if it affects the heart. Cognitive delays can also happen in some cases because dystrophin is expressed in some brain regions.
Let's talk about diagnosis briefly. If you had to choose the single most definitive test for Duchenne, what would it be?
Genetic testing. It tells you exactly what mutation is present and whether dystrophin is completely absent. We used to rely more on muscle biopsy, but now the biopsy mainly confirms what we already know genetically.
And treatment?
We focus on slowing the decline and preserving function. We give steroids to prolong ambulation. Physiotherapy is important to prevent contractures. Respiratory care is also crucial as the respiratory muscles weaken. And finally, cardiac monitoring to catch any cardiomyopathy. More recently, exon skipping therapies and gene therapy approaches are being introduced, but the results are mixed and accessibility can be limited.
Perfect. That's Duchenne, the severe early onset dystrophinopathy. Now we'll tackle a weaker version of muscular dystrophy. Alright, Mace, let's continue our dystrophin story with a new case. Picture this, a 14-year-old boy who's doing fairly well overall. He can walk, climb stairs, and play with his friends. But he's always been a bit slower than other kids in sports. Recently, he's been getting more fatigued during exercise, and his school nurse noticed mild calf enlargement. He doesn't show Gowers' sign the way Duchenne patients do, and developmentally, he's been on track. This isn't the classic early dramatic picture of Duchenne, so what does this pattern make you think of?
That's exactly the kind of presentation you'd expect in Becker muscular dystrophy, the milder cousin of Duchenne. Specifically, the later onset, slower progression, preserved ambulation into adolescence, and the subtle calf pseudohypertrophy.
So, if Duchenne is the complete absence of dystrophin, what's happening in Becker?
As we said, dystrophin isn't absent in Becker. It's reduced or only partially functional. The gene still produces the protein, just in an abnormal or smaller form. Because some dystrophin remains, the muscle membrane isn't as fragile. That means muscle breakdown happens, but much more slowly. That's why these patients walk longer, stay more functional, and have a much later onset of symptoms.
And clinically, how does their weakness tend to look? Is it still proximal?
Yes, still primarily proximal, hips and thighs first, but the decline is far more gradual. Some patients might not present until their late teens or even adulthood, depending on how much dystrophin they retain. Cardiac involvement does occur, but again, it's usually milder and later than in Duchenne. CK levels are also elevated, typically around 5 times normal, because remember, it still is a muscular dystrophy.
It's interesting. Same gene, same pathway, but such different lives depending on how much dystrophin the muscle can hold on to. So, if someone is diagnosed with Becker, how do we manage them?
The management is very similar to Duchenne, but just adjusted for the slower course. Remember what we talked about: physiotherapy to maintain mobility, monitoring for cardiomyopathy, and supportive care as needed. Steroids can still help, but it's not as urgent because Becker patients stay ambulatory for much longer.
So, that covers the dystrophinopathies, Duchenne, and Becker. How about we reinforce them with a practice question?
What is the classic presentation of Duchenne that distinguishes it from other muscular dystrophies? A hallmark feature is early, progressive proximal muscle weakness that appears in early childhood, often before age 5, and leads to difficulty standing, climbing stairs, and running. Also, look out for Gowers' sign, a very classical sign of DMD, because those hip and thigh muscles are the first to weaken.
Early onset proximal weakness plus Gowers' sign is classical DMD pattern. All right, one more question before moving on. How does Becker's present?
The key feature in Becker's is the later onset proximal weakness with previously preserved function for many years. Much gentler than Duchenne.
So, later onset, slow progression, and some dystrophin present is Becker's pattern. Alright, Mace, let's move on to our next case. Picture this one. A 17-year-old girl comes in because she's been struggling with gym class. She can walk fine, but running laps or climbing stairs wipes her out. She says her hips feel heavy, and her parents notice she sways a bit when she walks. She does not have calf pseudohypertrophy or facial weakness, just progressive weakness around the hips and shoulders. This kind of presentation doesn't really look like Duchenne or Becker, so what does this pattern make you think of?
This could be limb-girdle muscular dystrophy, or LGMD, another form of muscular dystrophy. This condition does not involve dystrophin like the previous two disorders, but you will see a similar pattern of muscle weakness. The name limb-girdle says it all. The muscles around the pelvic and the shoulder girdles, the limb girdles, are the ones that weaken first.
And unlike Duchenne and Becker, which are both X-linked, LGMD has a completely different inheritance pattern, right?
Exactly. One of the defining features of LGMD is that it can be autosomal dominant or autosomal recessive, depending on the subtype. The recessive forms are more common and often more severe, especially when symptoms show up earlier in life.
And when these patients present later, like late teens or early adulthood, the condition tends to progress more slowly.
Right. That's why your case is so classic. These patients often start with trouble in activities that require hip or shoulder power, climbing stairs, rising from a squat, lifting things overhead. Facial muscles are not usually involved, which helps differentiate LGMD from things like facioscapulohumeral dystrophy, which we will discuss shortly.
How do we diagnose it? Do we also look at CK levels?
CK levels are definitely elevated, but not always as dramatic as in Duchenne. We can do a biopsy, which would show muscle fiber degeneration with variable fibrosis, very much like the typical dystrophy pattern. But remember, you don't have the absence of dystrophin that you see in Duchenne.
So, the hallmark in limb-girdle muscular dystrophy is proximal weakness centered around the hips and shoulders in a teenager or young adult with a variable inheritance pattern.
Exactly. And because there are so many genetic subtypes, management is supportive. So things like physiotherapy, maintaining mobility, and monitoring for any cardiac complications depending on the subtype.
Now, let's finish off the dystrophy family with a lower yield disorder that we will discuss briefly for completion's sake. And that is facioscapulohumeral muscular dystrophy. This one's a mouthful. Picture this. A 20-year-old university student comes in because he notices difficulty smiling in pictures, struggles to close his eyes tightly, and his shoulders droop when he tries to lift his arms. When he turns around, you can see both shoulder blades sticking out like wings. Really prominent scapular winging, but his legs completely fine.
This is a classic presentation of facioscapulohumeral muscular dystrophy, or FSHD. There is facial weakness, scapular instability, and difficulty lifting the arms because the shoulder girdle muscles aren't supporting the movement.
So, if we break down facioscapulohumeral, fascio is for face, scapulo is for the scapula, and humeral is for the shoulder. And unlike Duchenne or limb-girdle dystrophies, this one doesn't start in the legs at all. What about the genetic pattern?
Genetically, it's very different from the other dystrophies that we've discussed, as it is autosomal dominant. This is important clinically because, unlike the X-linked Duchenne and Becker, FSHD can affect both genders equally.
So, to summarize, FSHD is facial weakness, scapular winging, and humeral involvement, usually in a young adult with preserved leg strength. Oh, and it has an autosomal dominant inheritance.
Exactly. Once you see that combination, it becomes almost unmistakable.
Amazing! That wraps up the muscular dystrophy family. Now we'll shift from muscular dystrophies to talk about a new group of disorders, inflammatory myopathies. A 50-year-old female comes in with progressive muscle weakness, difficulty climbing stairs, and trouble rising from a chair. CK is elevated and EMG shows a myopathic pattern.
Okay, so we're suspecting inflammatory myopathy or myositis of some kind.
Yep. Now we'll reshape the same case in three different ways to illustrate the different types of myositis, which are polymyositis, dermatomyositis, and inclusion body myositis. This way, we can see the special features of each disease even though they share a similar theme.
Let's do it.
In our first version, the patient has symmetric proximal weakness that worsened over weeks to months. No rash at all. Swallowing is becoming difficult, and biopsy shows inflammation deep inside the muscle fascicles, especially surrounding individual fibers. All right, Mace, walk us through the specific type of myositis and how we knew which type exactly it was.
This is classic polymyositis, and the key is the fact there is no rash, as well as the pattern of immune attack on the muscle. In polymyositis, CD8 positive T cells infiltrate the endomysium, the innermost muscle layer, and directly invade and damage muscle fibers. That cell mediated destruction of the fibers is the hallmark. Polymyositis presents with symmetrical proximal muscle weakness that gradually progresses over weeks to months, leading to difficulty with tasks like climbing stairs or lifting objects. Patients may also experience muscle tenderness or even dysphagia because pharyngeal muscles get involved.
Okay, so far we said that polymyositis is when CD8 T cells attack the endomysium, and patients present with progressive, symmetrical proximal muscle weakness and no rash.
Exactly. And because there's an attack on muscle and the fibers are continuously being damaged, CK levels are elevated.
Alright, yeah, that makes sense. And how is it treated?
Treatment generally involves corticosteroids first, often followed by immunosuppressants like methotrexate or azathioprine. Remember, there is an autoimmune attack on muscles, so we want to tone down the immune system.
Okay, now let's go back to our case and make some modifications to it. Our patient still has proximal weakness, but this time she has a violet rash around her eyelids, scaly red bumps on her knuckles, and an erythematous patch across her upper chest. The biopsy shows perifascicular atrophy and inflammation around small vessels.
Those skin findings are very characteristic for dermatomyositis. The purple rash on the eyelids is the heliotrope rash, and the bumps on the knuckle are the Gauthron's papules. The rash on the upper back, shoulders, and neck is the Scholl's sign. So it's like you're wearing a shawl over your shoulder. While the rash on the chest and anterior neck is the V sign, so it's making a V shape on the anterior chest.
How is the pathophysiology of dermatomyositis different from polymyositis?
Remember how in polymyositis we had CD8 positive T cells attacking the endomysium deep inside the muscle? Well, here we have CD4 positive T cells attacking the capillaries around the muscle fibers, leading to perifascicular atrophy, where the outermost fibers literally shrink from poor perfusion.
The way you can think of it is that dermatomyositis is attacking the outer part of the muscle, and because that part is closer to skin, we have rashes and skin involvement.
That's a great way to think of it.
Is there anything else we should keep in mind for dermatomyositis?
It is sometimes associated with an underlying malignancy, especially ovarian cancer, lung cancer, stomach cancer, colorectal cancer, and non-Hodgkin lymphoma. So you should really keep an eye out for these and do proper cancer screening as part of your workup.
Since polymyositis and dermatomyositis are autoimmune, are there any autoantibodies we should know about?
Polymyositis or dermatomyositis may both have anti-Jo1 antibodies. Dermatomyositis specifically may have anti-MI2 antibodies.
So anti-Jo1 is for both, while anti-MI2 is more specific to dermatomyositis. What about the treatment of dermatomyositis? Is it also corticosteroids and immunosuppressants like polymyositis?
Yes. Treatment is similar to polymyositis with steroids and immunosuppressants. But remember that in dermatomyositis, skin protection and cancer surveillance are crucial.
Now, let's put another twist on our previous case scenario. This time, the patient is a 65-year-old man. His weakness is asymmetrical. He keeps falling, and his quadriceps muscles seem much weaker than the rest of his legs. He's also having trouble gripping objects because his finger flexors are weak. The biopsy shows rimmed vacuoles and protein inclusions inside muscle fibers. This is a very different vibe from the other two.
Yeah, this looks like inclusion body myositis.
Our patient is a male this time. Is it more common in men?
Yes, it mostly affects older men, usually over 50.
And we also said that his weakness is asymmetrical.
That's another key feature that differentiates it from polymyositis and dermatomyositis. Inclusion body myositis is asymmetrical and it hits unusual muscle groups like the quadriceps, leading to frequent falls, or the finger flexors, causing difficulty gripping, opening jars, or making a fist.
Okay, so asymmetrical muscle weakness in an elderly male. What about the biopsy?
It has some characteristic features, including rimmed vacuoles and protein inclusions inside the muscle fibers, hence the name inclusion body myositis. There's also inflammation between the fibers, but not the classic CD8 endomedial pattern you see in polymyositis.
And do we treat it with steroids like the other two types of myositis?
This is the saddest part. Inclusion body myositis does not respond well to steroids or immunosuppressants. So it's important to recognize it early on to avoid unnecessary long-term immunotherapy, which won't even help the patient.
Okay, so polymyositis has a CD8 driven attack deep into the muscle, leading to symmetrical muscle weakness and no rash. Dermatomyositis has perifascicular atrophy due to CD4 T cell attack, leading to symmetrical muscle weakness plus the classic skin changes that we talked about. Inclusion body myositis, on the other hand, presents with asymmetric weakness, and biopsy shows rimmed vacuoles and protein inclusions.
You summarized it perfectly, Reema.
Let's take a quick question to test our listeners. What findings make you think dermatomyositis instead of polymyositis?
Polymyositis has no skin involvement whatsoever, so the presence of skin changes immediately points towards dermatomyositis. You would see the four classical rashes: heliotrope rash, Gautron's papules, Schultz sign, and V sign. It's very important to remember all four.
What's the feature that really separates inclusion body myositis from others?
It's asymmetry and selective weakness of quadriceps and finger flexors. That combination is classic for inclusion body myositis.
Now that we've covered inflammatory myopathies, let's shift gears entirely and talk about the neuromuscular junction instead of the muscle fibers themselves. Here's our next case. A 28-year-old woman comes in with double vision at the end of the day. She says her eyelids slowly drop as the day goes on. She struggles to keep her head up when she's tired, and chewing becomes difficult at dinner. Her symptoms improve after resting and are worse in the evening. This feels very different from the proximal weakness patterns we discussed earlier. What does this make you think of?
That's the classic picture of Myasthenia gravis, a disorder of the neuromuscular junction where the muscle itself is actually normal, but the signal from the nerve keeps failing because the acetylcholine receptors are under attack.
So the problem is fatigue after repeated use, not a constant weakness. Let's unpack the mechanism first. What exactly is happening at the neuromuscular junction in myasthenia gravis?
In myasthenia gravis, the immune system makes autoantibodies against the acetylcholine receptors on the postsynaptic muscle membrane. So every time the nerve releases acetylcholine, fewer receptors are available to bind it because the receptors are getting destroyed. Early in the day, the muscle might manage, but as the receptors become exhausted, the signal gets weaker. And that's where we see the fatigable weakness.
Why do they get ptosis and diplopia?
Because the extraocular muscles are some of the most active and fatigue-sensitive muscles in the body. They're constantly adjusting your gaze, so they're the first to give out when the neuromuscular junction is impaired.
I remember this disorder has something to do with the thymus. What's the connection?
It's actually a very important association. Around 75% of myasthenia gravis patients have some kind of thymic abnormality, either thymic hyperplasia or thymoma. The thymus contains myoid cells that express acetylcholine receptors, so it becomes a site for antibody production. That's why you need images of the chest as part of your diagnostic workup.
Speaking of diagnostic workup, let's go deeper into that.
We start with serology, looking for anti-acetylcholine receptor antibodies. If the patient is seronegative for anti-acetylcholine receptor antibodies, many will have antibodies against MuSK, another key protein at the neuromuscular junction. So we can also test for anti-MuSK antibodies. Then after serology, we use repetitive nerve stimulation. In this test, you would see a characteristic drop in response with repeated impulses because remember that there is a weakness after repeated use. Other than serology and repetitive nerve stimulation, the most sensitive test is single fiber EMG, which detects transmission failure between nerve and muscle.
We should also look for a possible thymoma.
Yep, we do a CT or MRI of the chest to check for thymoma.
Perfect. Now for management. What are the key strategies?
We have three main goals in the management of myasthenia gravis: symptomatic treatment, immune directed therapy, and thymectomy if applicable.
Let's start with the symptomatic treatment.
To relieve the symptoms of myasthenia gravis, we use acetylcholinesterase inhibitors, like pyridostigmine. The idea of these drugs is that by inhibiting acetylcholinesterase, we prevent the breakdown of acetylcholine, thus increasing the amount of acetylcholine available at the neuromuscular junction, and delaying or avoiding the fatigue that happens.
All right. So, acetylcholinesterase inhibitors like pyridostigmine as symptomatic treatment. And then for the immune directed therapy, let me guess, steroids?
Yep, as will be the case for most autoimmune conditions. We can use steroids and other immunosuppressive medications. Since we have autoantibodies involved, we can also go for IVIG or plasmapheresis to flush out all those antibodies. This is especially helpful for rapid improvement in severe cases.
Okay, and our last approach to treatment is a thymectomy.
Yes, it's indicated for either thymic hyperplasia or thymoma.
In severe cases of myasthenia gravis, there could be an emergency called myasthenic crisis.
A crisis happens when the respiratory muscles weaken so much that the patient can't breathe. It's life-threatening and needs ICU care with respiratory support and rapid therapies like IVIG or plasmapheresis.
So, to summarize, myasthenia gravis stands apart from all the disorders we talked about earlier because the muscle itself is normal. The problem is purely at the neuromuscular junction. That's why the weakness is fatigable, and symptoms vary throughout the day, and also why we see things like diplopia and ptosis. Wow, this was a loaded episode. Let's do a quick recap of everything we discussed. Starting with the congenital myopathies, the structural ones.
We have nemaline myopathy, which has rod bodies. Another one is core myopathy, which has enzyme poor cores. And finally, there is central nuclear myopathy, which has nuclei clustered in the center.
Right, and these usually show up with hypotonia, feeding difficulties, and sometimes respiratory weakness. Okay, those were the congenital myopathies. What about congenital muscular dystrophy?
Congenital muscular dystrophy shows weakness at birth, with early degeneration, higher CK, and often arthrogryposis from reduced fetal movement, so a floppy baby with frozen fingers. Next is spinal muscular atrophy, where the lower motor neurons degenerate because of SMN1 defects. Severity depends on how many SMN2 copies the patient has.
And those infants can be profoundly hypotonic with early respiratory failure.
Then we have Pompe disease, a metabolic disorder due to a deficiency in the enzyme GAA. This leads to glycogen buildup, causing hypotonia, cardiomegaly, and respiratory failure.
But thankfully, early enzyme replacement therapy can make a huge difference.
Exactly. And finally, congenital myotonic dystrophy, caused by CTG repeat expansion. In this condition, mothers show a mild version with delayed hand relaxation, while babies present with severe hypotonia and respiratory insufficiency.
After that, we discussed the major muscular dystrophies, especially Duchenne and Becker.
The defining features of Duchenne muscular dystrophy are early, severe proximal weakness in young boys with Gowers sign, and calf pseudohypertrophy due to absent dystrophin.
And how does this differ from Becker's muscular dystrophy?
Becker has a later onset, slower progression, and partially functional dystrophin, not completely absent, so patients are fine for much longer.
How about limb-girdle muscular dystrophy?
Limb-girdle muscular dystrophy causes proximal hip and shoulder weakness in teens or adults, with variable inheritance and no facial involvement.
We also talked about facioscapulohumeral muscular dystrophy.
This is where we see facial weakness, scapular winging, and shoulder weakness, usually in young adults. The legs are usually preserved.
Then came the inflammatory myopathies.
These include polymyositis, dermatomyositis, and inclusion body myositis. Polymyositis has symmetric proximal weakness with CD8 positive endomysial infiltration and no skin findings. Dermatomyositis has proximal weakness and skin rashes like heliotrope rash, Gottron's papules, Schall's sign, and V sign. Biopsy shows perifascicular atrophy and CD4 mediated vascular injury. The last one is inclusion body myositis, which is seen in older males with asymmetric weakness, especially of the quadriceps and finger flexor muscles. And biopsy shows rimmed vacuoles and protein inclusions.
And finally, myasthenia gravis.
This is a fatigable weakness from antibodies against acetylcholine receptors or MuSK at the neuromuscular junction, giving ptosis, diplopia, and weakness, especially at the end of the day. It has a strong association with thymic abnormalities.
And that wraps up on today's episode on muscular disorders. We hope this helped make the topic clearer and more organized for you. And special thanks to you, Mais.
Thank you, Reema. Take care, everyone, and see you next time on PodBites.